via femoral artery during minimally invasive cardiac surgery. Dr. Monaredo?
No, it's Larry.
Oh, okay.
That's all right.
Dear Chairman and colleagues, during the past decade, there has been an increased use of minimal invasive approaches for cardiac surgical operations, and the retrograde route for arterial perfusion via the femoral artery is often an option that can be utilized. However, during the past few years, there have been several concerns by at least some groups with respect to potential complications that may be associated with retrograde flow. In particular, potential complications such as neurological events like a stroke or retrograde aortic dissection. So very briefly, this is a paper that was published last year by an Italian group, by Dr. Glauber's group. And as you can see, it is outlined how these authors found that on multivariate analysis, the use of retrograde perfusion was a risk factor for stroke and also delirium. However, and this is what I'm going to show you in the next few slides, when you are going into the details of these papers, you often find that there is an association between the use of a retrograde flow and the endoclamp. Like, for example, in this study, the authors were also citing as landmark papers the one by the NYU group. But again, in this series, the use of a femoral cannulation, as you can see in nearly 80% of cases, was associated with the use of an endoclamp. And again, obviously, this was reported to be a detrimental factor in terms of outcomes. So conversely, other groups, for example, a few years ago, this group from Turkey reported very good outcomes when the femoral artery, but external clamping was utilized. And last year, there was this very nice editorial by Dr. Chitwood that was raising a potential room for discussion whether it was really the retrograde flow per se or maybe some comorbidities by the patients. So this is why we wanted to investigate in our group what was the outcome following retrograde arterial perfusion in patients undergoing minimal invasive cardiac surgery. By means of a retrospective analysis, and the endpoints, the primary endpoints were the occurrence of neurological events such as stroke or TIA, and secondary endpoints, hospital mortality, retrograde aortic dissection, or local complications at cannulation site. Exclusion criteria were patients obviously with acute aortic dissections, patients undergoing surgery of the aortic arch with severe atherosclerosis of the ascending aorta, or severe atherosclerosis or tortuosity of the femoral vessels. So over a more 13 years actually time span, we identified 496 patients. As you can see, mean age around 60 years, logistic Euro score around 4, and BMI 26 and BSA 1.8. With the prevalence of peripheral vascular disease, but deemed not to be critical in roughly 1/3 of patients. Obviously, as I said, this was a retrospective analysis of all kind of patients undergoing minimal invasive surgery. So we had patients undergoing, for example, mini sternotomy for aortic valve of ascending aorta with femoral artery cannulation, or patients undergoing mitral valve ASD, APFO, or other kind of procedures via a mini thoracotomy. This is a breakdown of the procedures being performed. As you can see, in nearly 40% patients underwent mitral valve surgery, in about 46% surgery of the aortic valve of the ascending aorta. And we believe, obviously, one of the key tools in this setup is the way you obviously perform your cannulation. This is done by, from the femoral artery standpoint, by a Seldinger technique, as you have seen, with 2 U stitches with minimal dissection of the vessel under T guidance. As you can see, the cannulas utilized were 18 or 20 French, so it's a Seldinger technique, and also we utilize centrifugal pump in all cases with retrograde flow. And again, the endoclamp was never used in this series, but all the time we use an external aortic cross clamping. In terms of primary endpoint, as you can see, the overall incidence of neurological events was 1.2. And in particular, you can see in the slide 0.4% incidence of stroke and 0.8 of TIAs. And if we look at a breakdown of the different kind of surgeries being performed, as you can see, there is a very balanced distribution among the type of surgeries. So no specific type of operation was associated with any neurological events. In terms of secondary endpoints, as you can see, the overall hospital mortality in this series was 0.8%. What we believe it was very important that the occurrence of retrograde aortic dissections was 0%, as well as femoral vessels dissection. We had roughly 2% of femoral nerve injuries and a very low incidence of lymphorrhea. Obviously, this study had several limitations since it's a retrospective study. We did not compare different strategies for perfusion. We obviously have a mix of different surgical procedures, and obviously, as you've seen in the previous slides, the low rate of postoperative events did not allow to perform a solid multivariate analysis. So, in conclusions, the arterial retrograde perfusion with Seldinger technique for femoral artery cannulation in association with a centrifugal pump can be considered a safe maneuver in minimal invasive cardiac surgery. Retrograde arterial perfusion per se is not associated with an increased risk of iatrogenic aortic dissection or major thromboembolic complications. Again, we didn't compare that, but our insight is that the avoidance of an endoclamping balloon may be beneficial in reducing the incidence of postoperative neurological events. And obviously, the use of peripheral arterial cannulations enhances the feasibility of minimal invasive cardiac surgery while reducing the drawbacks of central cannulation through a very limited access. Thank you.
Any questions?
Joe Lamelas from Miami Beach. I just want to congratulate you on your results. I mean, I've done over 3,000 cases, and 90% have been with femoral cannulation. And, you know, I think this is very important to get out to the surgeons because many fear femoral cannulation. I think your results are similar to mine, and I think, you know, it will allow surgeons to feel more comfortable doing minimally invasive surgery. So I just wanted to congratulate you on that.
Thank you, Dr. Lamelas.
I just had a question. If you have femoral vessels that are atherosclerotic, have you guys swung a chimney graft on it to help cannulate it?
Well, I have to say that actually I attended yesterday morning a breakfast session where Dr. Lamelas was presenting, and I think we share his same approach that you have obviously to evaluate the quality of the vessel, and if via preoperative Doppler scan or when palpating we have any concern, we may obviously not go for that route, but we do not routinely use this approach of chimney grafting. If the vessel is not severely atherosclerotic, by placing like 18 or maybe 20 French cannulas, it's very unlikely that you may cause severe issues or retrograde dissection. So we consider a pretty safe approach.
Thank you.
One more question?
I just wanted to make one comment. Sorry, I think with your question, I think if you put a side branch, I think the risk of retrograde dissection or problems are higher. I think if the cannula lies in the iliac or in the abdominal aorta, no matter what the atherosclerotic burden is on the aorta, because I've done that with patients that have aneurysms, severe atherosclerotic disease, I think the risk of stroke is not really there. I think stroke occurs more from inadequate de-airing, calcium, debris that's left in the aortic root, with the debriding of the annulus. So I don't think it's the atherosclerotic burden, because that has not translated into an increased risk of stroke in the cases that we've seen.